Good morning, everybody. Thanks for coming out as always. The last, any of you that were here last month when I gave grand rounds, we talked about Medicare, and I kind of thought it was just something that needed to be talked about because I know not many of us really spend much time thinking about that stuff. But I will say I probably got the most comments on that lecture of any that I've ever given. So I think it's something that we all recognize as a necessary part of our life. So kind of what I decided to do, rather than give a bunch of lectures that are specifically just about that, is I'm going to just have a little kind of word of the day type thing. So most of my lectures that'll be more clinical, I'm still going to just talk a little bit about that kind of at the beginning. And so I'm just going to pick a term or two and just really quickly just discuss them. So there's a lot of things, like I mentioned in last month, there's a lot of things that are happening in healthcare. And I think the biggest mistake we can make as clinicians, providers, people who are on the front lines is to kind of just let it happen to us and not be part of the changes that occur. So change is coming, that's just going to happen. And so I think the more we're aware of it and the more involved we are, the better it is for our patients and better it is for us who are the ones actually taking care of patients rather than just administrators, insurance companies, and things like that. So one of the terms that's been kind of a bit of a hot topic is surprise billing. So who can tell me in general what surprise billing is?
Basically, you gotta let the patient know what services they have, the cost, so they don't have a surprise.
Okay. So if a patient comes into my office, what's the likelihood if they have insurance, whatever, United, Cigna, Select Health, they come in, they see me, and they walk out the door, right? This is very different. None of us go in and buy a car and like pick the car and then walk home and then wait to receive the invoice in the mail, right? Okay. None of us would do that. But that's how healthcare is done. And so does my patient that I just saw in clinic run the risk of getting some big surprise bill from me in my office if they have insurance and that insurance is accepted by my office? Okay, how so? How are they going to get a surprise cost? What would that have to be?
They don't understand their insurance.
Okay, so it might not be that there's anything really surprising, just simply that they don't understand the deductibles that they have and everything else. You know, that's kind of a them problem, right? Not just simply understanding their own insurance. If they have a deductible that doesn't cover specialty care or something like that, that may surprise them, but the system isn't necessarily surprising them outside of what's well established or understood.
If you do something that wasn't approved.
Okay, exactly. So you do an injection, you do a procedure, you do something like that that you don't have authorization for. Insurance company says, we're not doing this. Then they do get a big fat bill, right? And it's typically going to be whatever billed charges are. Everyone who runs an office knows the billed charges are like, fairy tale things. And we charge thousands of dollars for something that insurance says that's worth $182, right? So that is kind of the biggest risk, and obviously that would be bad form, right, to stick it to your patients. You're probably not going to make it very long because patients will stop coming if that happens, okay? So in the office setting, it's not as big of a risk. The system itself, that requires a provider who's either really ignorant or intentionally trying to take advantage of a patient. The biggest risk is really more in inpatient settings, in hospital settings, and things like that. And this really is a big deal. And the system isn't necessarily set up to actually help protect patients, because these things can happen even though nobody's really intending or trying to make it happen. It can happen. So if somebody walks into a hospital for an elective surgery, okay, the hospital's within their network, the surgeon's within their network. How does that patient walk out of the hospital with a big surprise bill? That again is not their fault.
The insurance will deny something regardless of whether or not they previously approved it.
Okay, so insurance companies can kind of pull stuff. Okay, so they absolutely can. Assuming everyone's doing their job and is being honest and truthful in their work, you would think that would eliminate all of the bad things that can happen, but it doesn't. And I would say, especially around here.
Some other things that will happen in the inpatient setting. Sometimes you'll go to what you think is an approved facility that your insurance company tells you to go through, yet there'll be a provider.
Correct.
One or more providers who are actually out of network, and then now you have an out of network situation with those providers.
Correct.
As well.
And that's exactly what surprise billing is really, that's the main issue. And so that patient comes in, I do surgery on them, surgery goes great, they stay overnight or whatever, physical therapy comes in the next morning, I assume, the patient assumes, everyone assumes that physical therapist is part of the system. Turns out they're not, they're private, and their practice is not credentialed with that patient's insurance. So insurance says we're not paying for it, right? And all of a sudden the patient's getting a bill that's more expensive than their surgery copays were because they had physical therapy or something that next morning. The biggest one I see around here is probably anesthesia. So the hospital's approved, but the anesthesiologist is not, right? All of a sudden, here's a many $1,000 hospital or anesthesia charge that is no longer, that isn't part of their insurance, right? And so that's what surprise billing really is, and those are the issues that have come up with it. EMS services, right? You're laying there dying, somebody pulls up, picks you up, and takes you. So this happened on my farm, actually, in central Illinois. A worker got hurt, and an ambulance came and picked him up and flew him to St. Louis, broke his jaw and stuff. And he showed me the bill for the helicopter ride was $258,000. Right? Somebody who has insurance, like all of these other things. And so that can be a huge problem, right? That can be a big problem. If somebody comes in and they're a cash pay, right? They're uninsured, we all know, like I said, the charges that we charge are this high, and insurance contracts are all here. Well, just because someone's uninsured doesn't mean that you should be making them pay these charges that none of us expect to actually get paid, right? 6, 7, 10, 12, 20 times market, right? Then that would be considered surprise billing and inappropriate. We talked about the next one, which is the big one, which is why it's a little bit darker. And that's the biggest issue. And that's really, and I think everyone can kind of agree, this is where the system kind of lets people down. You walk into a hospital, everything's approved, your insurance, you've got great coverage, all these things, and all of a sudden you get a charge for an out-of-network provider that's functioning in that center that you were never told about, and that can become a big issue for the patient, for sure. And I think, again, all of us can agree, we wouldn't want to be in that situation, and none of us would want to take advantage of that. If you are considered out of network, then that moves into a different bucket, right? And so a provider that's out of network, not only, can they maybe charge whatever certain amount, but they can go beyond what, if you were in network, you would be paying as the full payment, and all of a sudden you're paying all the way up to these billed charges, which again are oftentimes huge, exorbitant. And so 2022, the No Surprises Act kind of came about, and so they are doing things to try to help control this. And this gives all of us kind of a bad name, whether we've earned it or not, and whether we're trying really hard to be good about this. But when you have patients that are concerned about these things, it's just good to be aware that this stuff does actually happen, and there are situations where providers have taken advantage of this, and they do this on purpose. There will be like co-surgeons or something like that, a surgeon that's in network, a partner comes in and joins that's out of network, and all of a sudden big charges and big payments. Okay, and if you're in a market where you don't care if these patients come back, right? There's a huge population and it's really all new patients. It's not return patients and all these other things. You can see how the wrong person can take advantage of that and devastate a lot of lives financially. Okay, so hopefully that's not all brand new and you understand what that is.
Question: when you take it to an ER, and your ER's out of network, I thought that's what surprise billing.
Yeah, that's part of that. Yeah, and that's part of that. The EMS, like, the ambulance, EMS stuff, the air flight, all of that stuff was a big issue. Yes. So if the hospital's out of network and you're taken there, they're making it standard to where you can't be billed out of network charges. And that's what the No Surprises Act did. That was one of the big drivers for that, was to try to help prevent that from happening. Because then none of us, as we're sitting there bleeding out from a neck cut or something like that, should have to be wondering, like, wait a minute, is this hospital covered? But the reality is, with the cost of health care, I mean, you may survive it and then end up spending the rest of your life trying to dig out of a hole, right? So that is absolutely, that's a big part of it. Just all of that has some place in that act, just like most of them. They're huge, not perfect, and hopefully they'll kind of tighten all that up. But of course you have a lot of interest, insurance companies and places that maybe don't want to have all this stuff, because then all of a sudden they're on the hook for paying for things that are out of network, which isn't necessarily just because they don't want to, but it's harder for them to make predictions on finances. You know, what percentage of these events are going to take place, and it's going to cost them more money, and those monies are going outside of their network and stuff. So it makes it a little bit harder to plan. But that's not a reason to stick it to the patients. So the other one, just real quickly, narrow networks. So this is a term that's been around for a while, but it's become a lot more common the last couple of years. Does that sound familiar to anybody? Okay, why do we do narrow networks? What's the point?
Well, sometimes that's cost control, or there's a couple of narrow networks. One being in Utah, Aetna has a narrow network where they have a separate plan that's considered part of Aetna, but it's really only within the Intermountain area.
Yeah.
And sometimes smaller HMOs will try and capture an area like, I don't know, Utah County or something. It will be their narrow network, and they'll maybe have somebody like United carry the catastrophic side if you go
Correct.
outside of that narrow network.
Yep.
Which is an interesting.
Yeah. Yeah, and then we'll kind of talk about that a little bit with HMOs versus narrow networks. And there's ultra narrow networks, which are even tighter. And really the whole philosophy is you really restrict and limit access to a certain number of facilities, certain number of providers, and it's a way to control cost. Of course, that can sound pretty good. So it depends on how it's framed, and in some ways it really can be. So say a narrow network, ultra narrow network is set up by, you know, looking at family medicine or primary care groups who have excellent outcomes, whose vaccination rates and all those other markers, diabetes, blah, 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 are exceptional. And then the surgeons within the network, or all of your specialists, have, you know, above average outcomes, show cost mitigation, and all of these other things. So you could be part of a really good, like really elite network that really provides excellent care. So that can happen. Most of the time it's not. It's more the cost mitigation, right? It's insurances need to be offered at a cheaper price to make it more affordable to a certain set of people. And so the way they can control that cost is by really limiting access. Can anybody think of anything that's happened in the last, 5 to 10 years that would have made these become really, really common?
The marketplace has definitely impacted that.
Yeah, the Affordable Care Act was really the beginning of all of this. And it was because there were promises and everything made about all of this affordable health care. And so, again, anybody who understands healthcare knows that it's just expensive. And, when you're talking $30 a month premium, couple $100 a year, I mean, that pays for nothing. That's like one visit, right? And so somehow those dollars have to come in. And so the way that they really kind of mitigated costs is by creating these really narrow networks. So 72% of the ACA marketplace plans in 2019 were narrow network or ultra narrow network. And so I remember when that came out, there were people who, lived in Central Illinois, and their nearest neurosurgeon within network was like in Denver, Colorado, right? And stuff. And so it was really tough. It was like you had insurance, but you couldn't really utilize it. And yes, it was a cheap premium, but it cost you thousands of dollars to travel across states to be able to get access to the providers. And so narrow networks can actually be a good thing, but they can also be a bad thing. HMOs can really function as a narrow network, and depending on how strict they are, they can do a lot of the same thing. The way HMOs can control cost is very much the same. They're very strict. They limit you to in-network, highly incentivized to be within network, but penalize you dramatically for being outside of that network. And again, in the big picture, that can be a good cost control for a population of covered patients. Where this becomes harder is rural networks and things like that, where access becomes more difficult, particularly the groups that already have a difficult time with access because of geography. Typically, HMOs do have out-of-network coverage, right? Whereas narrow networks typically have none. Like, you're out of network, you're totally on your own. And so then that becomes an argument. If you live in a highly urban area, your network is pretty readily available to you, then a narrow network may make a lot of sense and it may be a good thing to have. But if you travel much or you spend time in other areas and there's a chance you're going to end up needing care outside of that network, you're completely on your own. You're basically a cash payer at that point. And so then it becomes, did the money savings and premiums, saved you, say, $5,000 a year, does that get offset by any of these other out-of-pocket expenses that may have popped up or showed up? Okay? All right. So this was a little bit of a trial for me. I didn't want to spend too much time talking about this stuff, but hopefully at least you got something to think about. Again, as much as we can be aware, when a patient comes in and asks us a question about healthcare finances and how money happens, I think it's just a bad look if we don't have a clue, if we just really can't tell them anything. Because how can we expect our patients to understand it and navigate it without falling into pitfalls? And you can do a great surgery, you can provide excellent care, and an experience like this, that patient's then pretty upset. And for better or for worse, oftentimes they think that we had something to do with it, or that we could have changed it or could have done something about it. So I think the more aware you are, the better. Okay, so moving on to the dynamic imaging. So both these patients I've seen just in the last month or two, and I think they kind of just stood out to me as a good reminder for why we do some of the things that we do. I think anymore, we oftentimes, everything is MRI scans, and sometimes we feel like x-rays, like we get them because we're supposed to or something, but we don't even really look at them because it's like, I can't see anything, and we just get an MRI scan or a CT scan. And so this is kind of just reminding all of us that sometimes the little things, what little flags might exist to help you identify something, to help a patient along their course. So this 41-year-old female, she's had back pain for quite a while. It's gotten worse over the last few years, and then over the last months to a year or so, right leg pain started becoming more of a problem. Kind of sounded ridiculous, but had a lot of SI joint stuff. Just one of these, there wasn't really anything that kind of stood out as the cause or the problem. Had been doing all sorts of stuff, of course, slowly moved into the opioid world, because nothing else was working. So kind of a classic story, something that we see a lot in clinic. And this is what the MRI scan looks like. I don't know. Fairly unremarkable. It's not too dramatic. I don't think there's too much crazy about that picture, right? I don't know, a little bit of desiccation here at 4.5 compared to the others, but otherwise alignment looks really good. This is the 4.5 foramen. I will say that's a little bit higher in the foramen, so I'll show you a picture as we move down. But just looking at this MRI scan, I mean, from a surgical standpoint, I just think there's really nothing to do here. I'm not really sure. Maybe this is multifidus muscle something. Maybe it is just SI joint. Maybe it's piriformis syndrome. I mean, you kind of run the list, muscle spasms, all different kind of stuff that maybe is involved with this. Okay, same patient. That's like 2 slices away. I still don't see a lot of stenosis or anything like that. Anything different about that picture, though, than the previous one? Okay, what stands out, Brandy?
There's a lot of neuropathy there.
Yeah, correct, yeah. So the joints themselves aren't overly big, sometimes older patients, only 41, so an older patient, you'd see these great big facets, you'd see them kind of wrapping around and kind of, just really gnarly, abnormal osteophytic overgrowth and stuff like that. But this is a pretty big fluid space within the facet joint. And I think sometimes that, I don't know, maybe we don't pick up on that as quickly as we should. This one's so obvious, it's hard, and it's so dramatically different than everything else on the study. On the sagittal MRI here, right, I gave you this cut so that you could see it here. And so that definitely at least makes me think and ask more questions about, is there something else going on with this patient? The MRI scan, otherwise alignment and everything else looks pretty good. Now, if I saw that, it'd be like, well, that kind of explains back pain. If she's got like some movement or motion there, maybe that's painful. I'm still having a little bit of a hard time saying why she would have leg pain. Although if this is mobile and this is able to kind of open and close, it's not too crazy to me to think that this can be transferred forward maybe and is causing intermittent lateral recess narrowing. So I would expect clinically that this patient feels better when they're laying down, sitting and stuff. But when they're up, they're probably having those intermittent radicular symptoms. And the pattern was an L5 pattern as far as radiculopathy down the leg, which is exactly what I would expect in an L4-5 lateral recess stenosis. So this patient was sent to me for a stimulator for neuromodulation, and but obviously I kind of look at everything. I'm a spine guy, spine surgeon, and so I looked everything over, and I wasn't so sure that this maybe wasn't the issue. She had never had dynamic images at all, which surprised me a little bit. But to be honest, on the flexion extension, it's not that dramatic. Although just simply going, so here you can see there is a bit of misalignment that occurs when she goes up and with flexion. But what do you think about that flexion study? Not necessarily just the pathology, but just overall between flexion and extension. Yeah, there's not a lot of flexion, right? And that's a little bit of a caveat. And this was a lady who, comes in with crutches or a walker or a wheelchair because the pain is so severe for her. And so getting her to lean forward is very difficult. So I don't think she did a very good job of actually flexing. So it was kind of a very kind of limited flexion. I think it was like this, right? And so I think if if they'd have made her be a little bit more aggressive, you probably would have seen a little bit more translation. I'd say it's 2-3 millimeters. It probably would go up to 5 or something like that maybe. But still, to me, raised a significant question: is this what's responsible for the patient's symptoms? I love neuromodulation, I love stimulators, but not to treat an underlying pathology that's the source of the problem. So it's a combination of clinical presentation. Does it all make sense? And in this case, everything does line up with this pathology. There is some movement when she goes from laying down to standing up. You have to remember that laying down in an MRI scanner, you are laying down. So that's a supine study. And sometimes just simply going from laying to standing will show you what you need to see. If you only look at flexion extension, sometimes you'll see a spondy, but in flexion and extension, and it doesn't really seem to change much. Well, that doesn't mean that there's no dynamic instability, because then you look at their MRI scan or something and their alignment is perfect, right? So they basically slip or move as soon as they become upright. And then flexion extension, there's not a huge difference, but the real change is from supine to erect. So we'll see how the patient does. I actually did a stabilization, decompression stabilization on this patient. Haven't heard anything, so I'm hoping that's a good thing, because it's only been a week. Next patient, pretty similar. I mean, they're not that different. Same kind of story, older gentleman, longer history of pain. Has had pain a lot longer. The leg pain has been around longer. This person is in a wheelchair all the time. Laying down has no real complaints. Sitting does pretty good, but as soon as he stands up and tries to walk, it's over. Leg pain is horrific, probably drowns out a lot of even the back pain. Narcotics, kind of the same story. And the patient's really not walked hardly at all for 2 years as he's gotten treated. Okay, MRI scan. Okay, 4-5 again. But look at alignment here. Alignment's not too crazy to me. Looks pretty nice. Looks pretty good on that MRI scan. Similar to the other lady, the facets are kind of opened up there quite a bit. So anytime I see facet joint gapping, I'm pretty suspicious because that's really just empty space. And so unless they've somehow autofused or stabilized elsewhere at that segment, there almost is certainly going to be motion or movement. And I think in this gentleman, more so than in the younger female, there's already more baseline stenosis. And so any motion or movement there is more likely to cause impingement on nerve roots. And so his kind of story presentation with minimal symptoms when laying down, significantly worsened when upright, tells me that this is probably mobile and unstable, moving around. Okay. So same thing, I'm always going to get dynamic x-rays. Okay, so I put this CT scan, this is his CT scan, and you can see the alignment there. It's a little bit hard to see. This one's easier, a little bit easier to see, right? See the amount of motion, see how different this is than this. Okay, and I don't think there's a ton of change between flexion and extension. There is some. I think he moves a little bit more on flexion versus extension, but really you could have just upright x-rays, no flexion, no extension, no dynamic changes, and you would still see this significant change from supine to erect. And that's really all you need to see. And so I think, just understanding, there is a pretty significant role for me for x-rays in all of these patients. I'm not fusing or stabilizing anybody that's unstable. That's just what fusions do. And so, if I don't have some kind of dynamic instability or some kind of motion or some reason to stabilize the joint, then I'm not going to. And this really helps answer that question for me. And it tells me when there's motion, when there's a need to do something. And again, I'm not sure exactly why this patient he had received care for years and years and years. And I think we maybe underappreciate how important just x-rays can be at seeing this. And this is something that, again, anybody can do. Primary care providers, anybody who's working up patients, I think just understanding even just upright. So supine x-rays have very little utility to me, but upright are extremely valuable. So if a patient's going to get films, they haven't seen a surgeon, you're not really sure, I would just say stand everybody up. Just make sure they're erect, because they give us more information. Because almost always they're going to have a CT or an MRI scan, and that's supine positioning. So just having them stand up at least provides me additional information. Because if this patient was laying down supine, getting a cross-table x-ray, it would look exactly like this. And we'd be scratching our heads wondering why this guy's having all of these symptoms, right? So that was kind of my hope, and I tend to see most patients after they've received care for years and years and years and years. And so whenever I come across stuff that I just think, man, this should have been picked up on a long time ago and would have changed this patient's course or trajectory, I think that's just important for everyone to see. So hopefully that makes sense. Any questions? Hopefully everybody's pretty familiar.
I think when you order them, too, you do need to really give good instruction to
You
the
do.
tech.
Yep.
Because if you ask them to start bending forward, the tech gets upset. That's not what they learn.
Correct.
I mean, they call you on the phone and explain it to them.
Yeah.
And it's happened several times.
Yeah.
And there's a huge difference when someone's trying to just lean a little bit and trying to touch their toe or go as
Yep.
far down as they can.
Yep.
Those views are very different
Yep.
in any aspect. And they provide a lot of information, especially if you have to set capsule or any type of a piece that's stressed. You can see on the MRI, something like that.
Yep. And I always talk to the patients. I tell them, like, hey, I'm going to send you down for this study. I know it hurts, but you've got to bend forward. Otherwise, it's not going to show us what we need to see, and we're going to have to do it again or something like that. And so sometimes they'll come back and they'll say, and they'll be leaning, they'll be touching their toes, so I do think that's the key. And when you order it, you have to be very clear. Uprights, right? Flexion, extension. That's one of my biggest concerns when people show back up and they got just standard views. Because then I feel a little bit morally too. I'm like, okay, well, we're going to have to repeat these because these are useless to me. The patient's going to get another charge. And so when I was in my Illinois practice, the imaging was within our group, right? We're a kind of a bigger group. And I would make them go back and they would do it for free. It's a little bit harder here because I don't have that control over all these private places. But I do think that's an issue. I think if the imaging isn't done right, I think that's a problem. And it's not really fair to just always pass those the costs on to the patients.
Yeah, put in your order, I had one where they didn't do it, they just said no, they don't know what he was talking about, and it's in the order, and
Yeah.
they
Yeah, and then you can push back. Yeah, but if you forget to order it right or something like that, then you're kind of, now it's you. Like, now how are you going to deal with it, making the patient pay for it,
Mine's more of a comment, but I think of note, both of those patients had well-preserved L5S1 disc space. And so it makes me wonder about transitional segment or Bertolotti joint. And I think anecdotally, at least, I've seen those patients with a transitional vertebrae have more of this settled aesthesis in 4 or 5. So I think just a good note to have a high suspicion for those patients.
Yeah, it's very true. Why 4 or 5? I mean, anytime you see a disease level that's out of proportion to everything else, you should be thinking why. Like, why this? Why does this make sense? And it could be old trauma, right? I mean, it could have done something when they're youth that kind of started this cascade. It's hard to say, but you should always be suspicious for everything.
I was just going to throw in 2 cents about weight-bearing knee x-rays. You get a totally different picture on a weight-bearing knee x-ray than when they're laying down.
Yeah, yeah. Yep. The body is dynamic, and if you're looking for something, you have to think about how the x-ray is going to show you what you're looking for. And I think this is a great example of how things look in one position and then how significantly they change just by sitting up. Any other questions? Anything else? Okay. Thank you guys very much. Have a good day.